Okay. Let me get back here. So in terms of skin, hair, and nails, when we look at this first slide where it says the immune system, there's 3 lines of defense, line 1, line 2, and line 3. Look where the skin and the mucous membranes and secretions of the skin falls in this first line of defense. There's others, right? If you look down here, the first line of defense includes the skin, mucous membranes, the hair within the nose, the cilia in the upper respiratory tract, urine, perspiration, saliva, the gastric juices, and sebum, which is really wax in the ear. That's your first line of defense. Think of the skin to the body is like the cell membrane protecting the nucleus, the nucleolus, all of the organelles. You'll see how important the skin is, and we know it's really important because if you have like a first, second, or let's say a 3rd degree burn over a certain percentage of the body, the person's life could be at risk. So the skin is the largest organ, and it really does keep what's outside the body and keep what's inside. But in terms of immunity, we have healthy bacteria that's all over our skin. And you're going to see that there's going to be a whole strain of other disorders and we're already seeing it. I have friends of mine that are dentists. I have friends of mine that are dermatologists. We're seeing these staph infections and strep infections now here around the nose, the mouth, the gums. From wearing the masks extensively, it helps with one thing, but when it's for extended periods of time, I think the constant exposure to CO2, the carbon dioxide, is going to create a whole other set of problems. But not just that, it's the constant disinfecting of the hands. Prior to this, right, prior to SARS and COVID, there was a huge movement towards what we call the hygiene hypothesis. And a lot of research in terms of autoimmunity and systemic autoimmunity, not just organ autoimmunity. One of the theories was in terms of the hygiene hypothesis, that people were too clean, too sterile. You know, a mother may tell their child, don't touch that, that's dirty, get your hands out of your mouth. And yet, if you talk to certain generations, like my generation, we grew up where there wasn't this big movement on sanitation of the hands. There wasn't a big movement on, you know, something fell on the floor. We had the 3-second rule, 1, 2, 3, blow it, and then we would eat it. No big deal. And although it sounds kind of silly and I joke about it, from a scientific standpoint, we have very important bacteria on our hands, and it helps to kind of offset the bad bacteria that we may be exposed to. So when we use the hand sanitizer excessively, we destroy all bacteria, not just bad, but the good. It would be like Listerine. You know, gargling with Listerine kills all the bacteria in the mouth, not just the bad, but the good. And it creates and manifests a whole other set of problems. So this is what we're starting to see, is based on the hygiene hypothesis. You never really get to build up and transform bacteria on your body if you're always killing things and good things. So in a few years from now, I think you're going to remember this conversation that we had, and you're going to say, whoa, Dr. Lindner called it. There's always this pro and con to just about everything, right? So, okay, well, here's the good part to this for the short term, but what's the long-term consequence, right? Even with drugs and medications, we could think there's certainly a short-term benefit, but at the expense of what? And those are the things to keep in mind. So the skin as our first line of defense, we really have to respect it and take really good care of it. If it's neglected, if there's lesions, we know for diabetics, for example, if the collagen and blood vessels become a little bit weaker to the surface of the skin and they get these wounds or these openings, they can get some pretty severe infections. I had a patient not too long ago whose lower leg, where the tibia is, was so hot. I mean, you could cook an egg on that. It was hot, red, and swollen. And I remember taking a marker and I outlined this hot red spot for him. And I said, tonight, whatever you do, don't wash the ink off circling this spot. If the redness spreads peripherally and it starts to spread outward, you go to the hospital, take yourself right away. And that was on a Friday night when I saw him, and I was supposed to see him Sunday morning in my office. He never did, so I reached out, shot him a text message, and he said he was in the hospital and they may have to amputate his leg. And they didn't, thank goodness, but they did have to amputate his great toe. So as a diabetic, he did not know he was a diabetic at that point in time. Pretty large gentleman, about 6'7" at that time, about 470, 475, 475 pounds. Pretty powerful guy, very influential, politically speaking, in the Nassau County area. I don't want to say who he is for privacy, but pretty powerful and influential guy in our community. He's retired now. And anyway, when you're diabetic, many diabetics can't feel sensation to their feet. So they have these balance issues. They may tend to walk with a wide-based gait. And they have problems with methylation. There's that term methylation again that I think I mentioned last week. And when you can't methylate, you can't produce the myelin or the myelin sheath around nerves. And you can't make neurotransmitters properly. So in any manner, he didn't feel his feet very well, but didn't know that he couldn't feel his feet. He didn't know he's diabetic, didn't know he couldn't feel his feet. And he happened to have a lesion or a cut between his toes and didn't know it was there. And that's where the infection got into the bone. So thankfully, they only had to amputate his great toe. And it was a big wake-up call for him. I still take care of him. I still see him. And now I think he's about 350, 345, he's lost over 125 pounds. So the skin is extremely important. It's the first line of defense. And if something invades the skin, right, think of it as like a fence around the house, that would be a protective barrier to protect your property. And then you have like an alarm system on the windows, right? You may have cameras outside. You may have windows that are tagged with wires. And then if someone breaks through there, through the second line of defense, then we have a third line of defense. Someone in the house may be armed with a weapon or a gun. So then you have the lymphocytes and antibodies that kick in. Okay, so let me close that one out. And I think I still have that PowerPoint open, maybe not. Yeah. Okay. So what I'd like for you to do today in the next hour and 15 minutes is go through the integumentary, which is really skin, hair, glands, nails, a little bit more focus on the skin, a little bit on the hair, and a little bit on the nails as well. Is pretty important. The nails I really, really like, and I'll explain why in just a few minutes. The skin helps to maintain the body temperature, and it's really important in making hormone D. We call it vitamin D, but it's really a hormone because the sun hits the skin at this 90-degree angle somewhere between the last week of May and, I think the very end of September. From the end of May to September, we have direct sunlight. the sun feels a certain way when it hits our skin, and it doesn't feel that way in October, November, December, January, February, March, April, and early May. So the sunlight hitting the skin, we have this subcutaneous cholesterol that's on the skin and allows us to make these vitamin D precursors. And then those vitamin D precursors go to the liver, where it makes more vitamin D precursors. And then its final pit stop is the kidneys, where it hydroxylates it again. And we get something called active vitamin D, or cholecalciferol.
Professor?
Yes.
Sorry, what chapter is this?
Integumentary, you'd have to look it up. It's called integumentary, though.
Is this going to be on our exam for Tuesday?
Nope, no, it's not. Exam number 2.
Okay, okay, so you're moving on already.
Yes.
Okay.
Yeah,
but
we can't.
We're not supposed to go over this yet. Like, it's okay if we haven't gotten to this
Yeah,
yet?
yeah, you're going to do this today. This is what you're supposed to do this week.
Okay, thank you.
Yep. Yeah, I have not expected you to do this. This is what you're going to be reviewing today. This is this week's lecture, along with that video that you're going to watch. I'm just kind of giving you the preview of what to kind of focus in on. Second exam is this, and the introductory to bones. It's a pretty short topic. It goes pretty quick, okay? The skin, you'll see, will provide sensory information because we have these little hairs on our arm, and it sends sensory input into the body. So you know if an insect is crawling on you, or you know, anything that could be potentially dangerous, the skin could warn you of a lot of things. The hair can warn you. So it maintains homeostasis as well, because you could be exercising, you can be hot, and then you sweat, and then you lose some of that heat. I take my temperature often, not only of myself, but every one of my patients as they come in, as part of the, you know, a health screening. And I always take my temperature first. I think it's kind of rude to point an infrared gun at someone's head or their neck as a greeting. It just seems very rude. So I always point it to me first. And it just kind of seems like it's a little bit more friendlier that way. I also don't like pointing it to the head. I just kind of go on the side of the neck. You know, skin is skin. The temperature is the temperature. It's not going to change much from here to here. So in my office, it's very physical, and I do a lot of work in the office, and I sweat. You know, I'll wear a mask, and then I'll wear a shield. And because I'm wearing that shield, I'll perspire. But when I take off and I check my temperature, it could be 94 degrees, 95 degrees, and they're 97, 98. And they go, "You okay?" I go, "Yeah, I'm sweating." And when you sweat, the whole purpose of it is to cool off the body. Okay. All right. This is a really great slide. I happen to like it quite a bit because it shows the connection that the integument has to every other system. So if you didn't think that the skin is connected to the skeletal system, or the muscular system, or the nervous, or endocrine, or to the urinary system, or digestive, make sure you take some time to kind of understand the connection of the skin, hair, and nails to all of these other organs, how they feed each other. Very important to do that. The skin makes up about 16% of the total body weight. Make sure you go over this slide as well in terms of all of its functions. You'll go over the different layers of the skin, the epidermis and the dermis, as well as the hypodermis, also known as the subcu or subcutaneous. This slide just happens to show you the upper portion here, which is epidermis. When you do the epidermis in today's lecture, you'll hear me talk about the 5 different stratum layers to the epidermis. They're microscopic. The top layer is the stratum corneum, which is made up of about 25 to 30 dead layers of stratified squamous epithelium. Now you know what that is based on what lecture we've already done, but it takes about a 4-week journey for the cells of the bottom layer, which is called the stratum germinativum or stratum basal, to migrate upwards to the top where they end up sloughing off, which is why it's really important to change your bedding every week, to change the bedding, to change the pillowcases, because you have dead skin cells on there. So you'll be very familiar with the 5 layers of the epidermis. And then when we move down to the deeper layer, it's the dermis, a papillary region and reticular region. And then underneath that, we have the subcutaneous, or the hypodermis. Now, the reason why skin is the very first system that we cover first after we've covered the tissues is that the skin is made up of all 4 types of tissues that we've already covered. It's made up of epithelium, it's made up of connective tissue, it's made up of muscle, and it's made up of nerve. So keep that in mind when we look at the skin. Also, you can understand that blood vessels are only found in the dermis. So if you have a cut and you're not bleeding, it's safe to assume it's superficial and only in the epidermis, because the blood vessels are in the deeper layer, in the dermis. In the dermis, you will find some of the accessory structures like the sweat gland, which is called a sudiferous gland. And then we also have oil glands called sebaceous glands. This is you'll see up here on the right, you can review the different stratum layers. I think I do a little mnemonic. Cher loves getting skin Botox. Cher loves getting skin Botox. Little mnemonic to remember the stratum layers of the epidermis from superficial to deep. But you should also know it from deep to superficial. On an exam, I could ask it one of 2 ways. In terms of seeing a dermatologist is extremely important, right? Derma is skin. And you know, it's interesting. Dermatologists and chiropractors, I think, don't get enough credit. Being a doctor of chiropractic, I can attest that I think dermatologists and chiropractors are such an essential part of the healthcare team, but misunderstood. I think everyone should go to a dermatologist every single year, just like, you know, if you were a woman and you go to the gynecologist once or twice a year, the dentist, you know, twice a year, the eye doctor once a year, you should also see chiropractors and dermatologists. There are things that could be hidden and be quiet that you may not be aware of. From a neurological perspective, super important to get your neurology checked and your spine checked by a doctor of chiropractic, and make sure that your overall epidermis from head to toe is screened. There's so much, 16% of the body is skin. You want to make sure that it's thoroughly evaluated and looked at. There are certain things that can affect the epidermis. Then there's certain types of burns that can affect the epidermis and the dermis. That would be more of like a 2nd-degree burn. And then you can have 3rd-degree burns that go right through all the layers, including the subcutaneous. In terms of painfulness, believe it or not, your 2nd-degree burn is much more painful than a 3rd-degree burn. The reason being, in a 2nd-degree burn, you blister up and the nerve endings are still intact, so you can feel the pain associated with blistering. But in a 3rd-degree burn, it burns right through most of those superficial nerve endings, so you're not feeling the discomfort, although the 3rd-degree burn is probably most dangerous and most life-threatening. You will go over the 4 different types of skin cells. Very important to know the Langerhans cells, which is an immune cell, and the other name for the Langerhans cell is also known as a dendritic cell. Dendritic cells are sometimes referred to as antigen-presenting cells, where they trap some sort of antigen and present it to the immune system. So sometimes the Langerhans cells are referred to as dendritic cells. Okay, you'll make sure you go through those 5 layers. Here's a little description of it. Here's a description of the 2 primary layers of the dermis, papillary and reticular. Again, this is just an overview. You're going to watch my video after this, okay? Here, we talk about the dermis, where there are macrophages. Now remember, macrophages stem from monocytes. A monocyte is a type of white blood cell that's always in circulation. And then when it finds a problem, the monocyte dives into the tissue and evolves from a monocyte into a macrophage. And then macrophages can have a variety of names depending on what tissue they're found. So they could be found in the skin, maybe they're a dendritic cell or Langerhans cell. They could be in the liver where they're called Kupffer cells. They're in the brain and they're called microglial cells. They could be in the blood where they're attacking oxidized cholesterol and they're called foam cells. So macrophages are found in the dermis, and in fact, it's the macrophages that are responsible for holding tattoo ink. When people get inked or they get tattooed, remember, you're injecting a foreign protein into the system, and the immune system will attack a foreign protein. And the macrophage engulfs it and holds it there for years and years and years and years. Okay, so the phagocytes, it's a phagocytic cell, which means it's cell eating. But that's where the tattoo ink is held. There is some evidence that's starting to emerge. And I've seen this within my family because it happened to my mother-in-law, where certain people, and this is where family history comes into play. When you do a health history, if you come from a lineage or a family lineage where there's autoimmunity, maybe there's leukemia, maybe there's MS, maybe there's cancer. If you are from the offspring of a mother or grandmother who have some degree of autoimmunity, I think twice about getting tattoo, because the tattoo ink upregulates the immune system to work really, really hard. And it can, like a domino effect, you push one domino, and if you ignite an immune system, if it's trending to autoimmunity, it's just enough to push it over the edge. And this is what happened to my mother-in-law, where she got a tattoo when she was, I don't know, I think early 60s. And it wasn't anything big. It wasn't like she got her entire back done or a sleeve or anything. Like, she didn't do that. She just kind of had her children and grandchildren's names placed on her wrist. And it triggered an autoimmune reaction and brought leukemia to the surface. And it happened very shortly after the tattoo. So was it cause? We can say that there's a degree of association there. It's really hard to pinpoint to say that's what caused it, but we could say that there is certainly an association between the two. So if you can walk away from anything like this, if you're thinking about it, like anything else, make a responsible decision and go, let me look at the family lineage here. Let's look at the genetics. Do I want to chance it? Is it worth it? Do I not? All right, so just think about that.
And Professor, do you have tattoos?
I don't. Thought about it many times, but I don't. Never had an earring and never had a tattoo. Funny story about the earring, though. I will share the story with you. We'll take a little break here for a second. But I was about, I think it was 18 or 19, and my buddy said to me, hey, why don't we go get earrings? So we went to Hicksville. It was called Mid-Island Mall at the time. Now it's Broadway Mall. And we went there in the middle, and they had a station where they would do the piercings. So my buddy went first, and they put the earring in, they put the gun halfway through. When he heard the click, he moved and jerked his head. And when he jerked his head, the earring was still halfway attached to the gun and only halfway through his ear. And he just kept saying, ouch, ouch, get it out, get it out. And there I am cracking up. I'm hysterical. I'm on the floor. I'm practically peeing on myself from laughter. And I'm looking at him and he's like, I'm going to kick your butt. I can't believe it. So what ended up happening was he got the earring. And as a result, I never did. I was too petrified based on his experience. Okay. All right, so let's see what else we have. Dermatitis, right? Anytime you add the word titus or itis to anything, it means inflammation. Okay, so dermatitis is inflammation of the papillary layer of the derma. Okay, let me just go through here. Very important to go through the skin pigmentation, understand what melanin is, what hemoglobin is, keratin. These are all things that add to the pigmentation of people. Melanin. Most of us have the same number of melanocytes, but we each push out a different amount of the black pigment, and that's what mela means, like melanoma. It's the black substance. So each of us, and don't confuse melatonin with melanin, they're different. So again, each of us have about the same number of melanocytes, but each of us produce a different amount, which gives us the variations, the skin tone, from yellowish to tannish, to olive skin, and to black, and different shades of black as well. Melanocytes convert tyrosine, which is an amino acid, into melanin. And it requires an enzyme called tyrosinase in order to do that. So if you look down below, there are people who are albino or that have albinism, where they have an inherited lack of tyrosinase. So you have nothing that convert tyrosine into melanin, and they look very pale and very white. That's an albino. Freckles is just the opposite. That's where you have a concentration of melanocytes in one spot. So when the sunlight hits it, that one spot becomes darker in relationship to the adjacent areas, which appear lighter. And vitiligo is the classical condition that Michael Jackson had, which is an autoimmune loss of melanocytes. And that's why he started doing all of the skin bleaching through the years. If you look at his skin color from when he was younger as a child to when he died as an adult, you'll see that he was much, much lighter due to this many skin bleachings that he had gone through. So vitiligo is an autoimmune loss of melanocytes in certain areas of the skin. People you'll see tend to have vitiligo on the upper eyelids. Sometimes they'll get it around the lips. You can see it around the fingers, patches on the arms and legs. Not life-threatening by any means. It's just more cosmetic. So review keratin and hemoglobin. I go through jaundice, cyanosis. Cyanosis or cyanotic is pretty easy. The bluish, because everyone knows if you have a printer and you need ink cartridge, the cyano is the blue one. That's cyano. Cyanosis is, God forbid, every year we hear that there's a baby or a child that falls in a pool and drowns. They pull the baby out and they see the nails are blue and the lips are blue and the ears are blue. That is cyanosis due to depletion of oxygen. That's why veins are blue, right? Depletion of oxygen. Erythema, like erythrocyte, is just redness. It means redness, like an infection or an allergy where your skin turns red, or inflammation in general. Okay, let's just see what else we have here. Some of this is review. Skin is not waterproof, it's just water resistant. So what your body does, if you're in a hypertonic solution or hypotonic, is different. Your body can either swell because you're absorbing water, or you can dehydrate and lose water depending on if you're hypertonic or hypotonic. The water, you're submerged in a hypertonic solution. If you're in a pool, you're more in a hypotonic solution. Hypertonic referring to the amount of solutes, like salt that's in an ocean water. If you're in a traditional pool that's not a saltwater pool, it's considered hypotonic. So you can lose water. Water goes from an area higher concentration to lesser concentration. If you're submerged in ocean water for a few hours, you're going to lose water content from your body to the ocean. You can become dehydrated.
Professor, I think some people are in the waiting room.
Oh, thank you. Okay, let's see.
No problem.
Okay, welcome back. Got kicked out? You got booted again? You there, Dante?
Yeah, hi. I got kicked. I was in the waiting room for a while.
Okay, I'm glad you're back. They saw you.
Okay.
Try and stay with us this time. Hang in there. Okay, let's see. We'll go through psoriasis, which comes from the Greek word pasati. Pasati means fish. If you look at the skin of fish, it's very silvery and shiny and can shed. And this is what happens with people with psoriasis. They tend to get it behind the ears, the elbows, the knees, the back of the occiput, and it's a very accelerated form of shedding of the stratum corneum. Make sure you know the difference between UVA, UVB rays, very important. And also melanin, I'll go through that in the lecture, so pay attention to that. In terms of the accessory structures, there's hair throughout the body except the palms, the soles, and the lips, and the external portion of the genitalia. Hair does have very important functions. Some people are like, well, what's the purpose of the eyebrows? It's kind of like a sweatband, right? If you're sweating and sweat comes down, if you didn't have your eyebrows, sweat would go right into your eyes, but the eyebrows also absorb UV rays. This is why you see some professional athletes, if they're playing baseball or football and they have to look up, the UV rays can scatter. Some of it hits the eyebrow, and then they put the black underneath to kind of to deflect away from the eye. And it also allows sweat to kind of funnel around the periphery, around the outer part. Eyebrows are really important. I use them significantly when I do my physical exam on my patients, because people that tend to have the outer 1/3 of the eyebrow not being present is usually an indicator of thyroid imbalances. Usually a hypoactive thyroid, the lateral 1/3 of the eyebrow will be gone. Pretty good indicator of that. Plus you see the eyes, if it's hyperthyroid, the eyes tend to bulge out just a little bit. They call it exophthalmos. You'll review the smooth muscle of the skin, the erector pili. You'll go over the hair root plexus a bit, as well as the oil gland known as the sebaceous gland. Really important because the oils move from the sebaceous gland, they move up the shaft of the hair, and it creates this antibacterial and water-resistant seal around the shaft of the hair so that bacteria doesn't get in. When you get bacteria that finds its way in down the hair shaft into the sebaceous gland, that's what acne is, okay? So also washing and cleaning off your skin excessively can clear away a lot of that antibacterial oils that move up the hair. You really want those there. When the erector pili muscle contracts and it pulls, whoops, let's go back, it pulls the hair follicle this way and the hair stands on end. That's what gives you goosebumps, okay? Part of that sympathetic response. So you go through some of the functions of the hair. I do go over that quite a bit. The importance of EPA, which is eicosapentaenoic acid, which is found in fish oil, as well as DHA. EPA and DHA is really important for the skin. Dexahexaenoic acid, which is part of the omega-3 family, really important for skin. Sebum is the wax that you find inside the ear, super important. You should know the difference between merocrine glands and apocrine glands. Review that. the difference between what a ceruminous gland is. Cerumen is also sebum, right? It's the wax that you find in the ear. Mammary glands produce milk. Important to know that both sexes actually have mammary gland, but they're rudimentary until puberty. And with estrogen, the mammary gland will develop. And if you're testosterone dominant, then they won't develop. You should be familiar with, again, the sebaceous gland is the oil gland, ceruminous glands. Whoop, let me go back here. That's your modified sweat glands that are in the ear that create sebum. And the eccrine glands, these are the most numerous throughout the body. And the apocrine glands, these are found mostly in the hairier areas. You can find that sometimes, like around the pubic area and around the armpits, when you sweat there, it can be a little bit more odorous as a result, especially in darker places. If your arms are downward and you're sweating, the bacteria are going to give off gases, which is what gives off body odor. Okay, that's why many people use deodorant. What the deodorant does is it closes the sweat glands, right? It has a lot to do with the sweat glands remain open because you have the same charge on both sides of the sweat glands. Remember, if you have a positive and a positive, they don't attract, they actually repel. So the sweat glands stay open. But once you put deodorant or anti-deodorant in there and you put a negative charge, now you have negatives and positives, and it closes up the sweat gland so you don't perspire. I want you to review the nail, the different parts of the nail. Back here in the nail root, just deep to this is where you have the matrix, which are stem cells. They multiply and divide and push the nail forward till it becomes the free edge. That would almost be analogous to the stratum corneum of skin, where you have the basal layer, which has your stem cells, and it pushes the layers upward till eventually they slough off. So here's a sideward view of the distal phalange of the finger. So here's the phalange, here's the nail, here's the cross section. So you can see back here is the nail root, and posterior to that is the nail matrix. Okay, this is where you have dividing cells, which will produce the new nail cells and end up pushing this forward. What gives this the pink appearance are the blood vessels that are deep. And when they're oxygenated, they'll appear pink. When they don't have enough oxygen, they'll appear white or pale, which is one of the other indicators of anemia, is looking at the fingernail colors. Many people have white. This will be pale. That's a sign of anemia. Not indicative of iron deficiency anemia. Maybe it is. Maybe it's B12 anemia. We don't know. You'll go through some of these nail deformities like clubbing of the nails. You'll see this a lot with people with cardiac issues or lung issues. You see how it becomes thick and it starts to curl down. They call that clubbing of the nail. You see that with lung pathologies like lung cancer and even cardiac issues. Cardiac issues only because the heart is involved in pumping oxygenated blood. When you can't pump oxygen to the tissues, especially the capillaries at the most distant parts away from the heart, which are the fingers and toes, they'll appear to be pale. The opposite of clubbing of the nails, you see how the cuticle area back here becomes a little bit hypertrophied and thicker. You get that angle, and here in normal it's flat. Then it starts to thicken a little bit, then it gets really thick, is you get spooning. Spooning of the nails are seen with fungal infections, diabetes. Here's the white nail for anemia. That's malnutrition. You can see it in liver disease or heart failure as well. Here is yellowing of the nail. Right? Have you ever seen that? So this could be from respiratory issues, severe bronchitis. It can be a result of swelling in the hands, which is called lymphedema. Here you start to get pitting of the nails, where you start to get these little indentations and these pits. So the pitting here, sometimes you'll end up seeing this with psoriasis. So when we look at this, we want to look at the skin and see if they have the flakiness at the back of the scalp, the elbows, the ears, the knees. You can also see this with other issues like alopecia, which is an autoimmune issue where people lose hair in patches. Here's another view of what clubbing of the nails can look like. You'll see it with low oxygen, which is why we'll see it in lung cancer or serious lung disease. We'll also see it with inflammatory bowel disease, severe cardiovascular issues, liver disease, and AIDS. Here's spooning of the nails. We'll see this with people who are iron deficient, anemia. We'll see it with people who are diabetics. We see it with hypothyroidism as well. These are Terry's nails. You see how there's this brownish, dark band going this way? That's called Terry's nails. This is usually seen with liver disease, severe liver issues, congestive heart failure, and in diabetics. So the nails, you know, again, the very first part of my exam or any exam is inspection. You always look at the person. And I would shake their hand, turn the hand over real quick just to inspect the fingernails. But as they shake my hand, I'm also looking at the strength of their hand. It tells me a lot about their muscle mass and about protein consumption. And then I look at the fingernails, and it tells me a lot about what's happening metabolically. Here is Bow's lines, these indentations that run across the nails this way. So we'll see this in malnutrition, but we'll see it in heart attacks and liver disease, mumps, measles, a lot of zinc deficiencies, a lot of metabolic disturbances will show these horizontal indentations going across the nail.
I have a question.
Yeah.
How long would it take for them to appear?
It depends, because it could take, like if you were to bang your nail like with a hammer, and then it, you know, it could take about 7-8 months for that thing to fall off. So metabolic issues can take years to develop, right? You know, someone just doesn't become diabetic or zinc deficient in a few days. So these things start to show up gradually. It can happen in months, not more like weeks, but more like months. Here is the bluing of the nails. We'll see this in, they call that cyanosis. And again, it's decreased oxygen. This should be bright pink, but when you start to see the bluish tint, it means that there's lack of oxygen. So anything that's going to deprive the person of oxygen, could be asthmatics, could be severe emphysemic bronchitis, any type of respiratory issue. There are certain drugs that can do it, overdosing in certain narcotics, benzodiazepines, and even certain sedatives are known to do that. This one I've seen several times. This is pretty common to see these streaks of melanin down the fingernail. It could be indicative of a certain type of skin cancer called subungual melanoma, and it's a very, very dangerous type of skin cancer. So it's really important, if you see this, you know, notify the dermatologist for sure, and then they'll probably work with an oncologist.
Excuse me, I have a question.
Yeah.
About the yellowing of the nails, could that also be a sign of liver disease?
It could be jaundice, but before you see it in the nails, you're going to see it in the eyes.
Mm-hmm. Yeah,
Uh,
because bilirubin, I think, the increased concentration.
exactly. You'll see the nails may be one of the last places to see it, but you'll see it first in the face and in the white of the eyes. And that's a really good indicator, especially if you have darker complexion. You're not going to see yellowing of the skin, right? If you're an American African, you're not going to be able to see that. So, but if you pull the eyelid down and you look at the white of the eye, you can certainly pick up anemia and jaundice. Anemia, if you pull down the eye and you look at the lower eyelid on the inside, it should be pink. If it looks pale and white, and then you see white over here at the nail bed, and then they stick out the tongue and it looks pale, now you got 3 indicators. And then they tell you that they're fatigued and they're tired. So it tells a little bit more of a complete package there. Some people have these vertical ridges that you can see this way. These are seen in diabetes, certain thyroid disorders, Addison's disease, which again is an endocrine disorder, B vitamin deficiencies, and people under severe stress. So just be familiar with some of these conditions. In terms of wound healing and skin cancer, I don't think I ask questions necessarily. It's not like you're going to have to identify these different types of cancer, but I've put these up here to stress the importance of everyone having a dermatologist, right? Just, you may think it's normal. Someone else will see it, the dermatologist, and say, oh, that's nothing to worry about. Well, they're the expert. But I can tell you a true story. I remember this woman I saw about 20 years ago, and she had this little bump on her cheek. And I noticed it when she was on my table face up. Her name was Mary Ellen. I said, Mary Ellen, what's that thing on your upper cheek over here? She goes, I have an appointment with the dermatologist at the end of the week. And she was very fair skinned. She goes to the dermatologist, she comes back, and I see she has a Band-Aid, and she lifts it up, and I can see they took out a pretty good chunk of her in terms of a biopsy. And anyway, it was about 2 weeks later, maybe 10 days later, she came back and she was like, oh, I'm so relieved. They said it was benign. And I said, oh, that's great. Did you get a second opinion? She said, no. They said it was benign. I said, Marianne, you know what? Look, it's always good to get things double checked. The fact that they went as deep as they did for that biopsy concerns me. And, oh, okay, I'll think about it. Anyway, that was the last time I saw Mary Ellen. I get something in the mail about 2 to 3 years later, and it's from an attorney requesting documentation on Mary Ellen. And I said, oh my gosh, was she in a car accident? Did something happen? And I go through all the paperwork and I see a death certificate. I'm like, oh my God, what happened? So I reached out to her daughter and I said, I got something from an attorney about your mom. What happened? She said, I don't know if you remember, but a few years ago, she had this thing on her cheek. And I'm thinking like this, oh my gosh. She said, they read the wrong report. They told her it was benign because there was a mix-up in the records. And sadly, that was a malignancy that metastasized. And in 2 weeks' time, it spread into her maxilla, right into her brain, and she was dead in about 2 weeks. So they were asking for all the doctor's records in terms of malpractice, and I guess going after the dermatologist and the labs. Just a very, very sad story in terms of the importance of second opinions are great. Really, whether it's good news or bad news, just, can I verify that? I want to verify it. Be familiar with first. Yes.
There's someone in the waiting room.
Yeah, okay. We're going to finish up here. So here's the first, second, third degree burns. I want you to be familiar here with the percentages of the body. You see how here the anterior shoulder, arms, forearm, and hands is 9%. So that means like up here is 4.5%, down here is 4.5%. So you get 9. And then the trunk is 18%. The genitalia is 1. The front of the thigh is 9. The back of the thigh is 9, right? This and this is 18. The back is also 18. So I want you to be able to figure out percentages on an exam question. If I say the anterior head and neck, the front of the shoulders, or the front and back of the shoulders, arms, and hands, and the genitalia are burned, what percentage of the body is burned? So just, expect one question on the percentages. Okay, so I think that's it. Let me stop the screen share there, and